Hello, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today I have a general surgery lesson for you, that is review of blood transfusion reaction. Please subscribe to our channel if you have not subscribed yet, and don't forget to give us a like at the end if you find the video useful. So let us not waste time anymore and start right now. Transfusion reactions are adverse clinical events that are seen after whole blood or blood component administration. Components may be red cells, white cells, platelets, plasma, cryoprecipitate, or clotting factors. Technically, a transfusion reaction will result if antibodies present in the recipient serum do not match with the donor cells. Blood transfusion reaction is a pro-inflammatory response to incompatible donor blood cells or products. Transfusion reactions are classified as acute or delayed. Acute reactions are immune or non-immune mediated adverse reactions that occur during or within 24 hours of the administration of blood products. Delayed reactions occur days, weeks, months, or even years later. They range from mild urticarial reactions that may be treated easily to fatal hemolytic reactions. Human error is the most common cause of fatal reactions. Transfusion reactions require immediate recognition, laboratory investigation, and emergent treatment. If a transfusion reaction is suspected during blood administration, stop the transfusion and keep the intravenous line open with normal saline for medication. Blood transfusion reactions occur in approximately 10% of all transfusions, but less than 0.5% are serious in nature. Transfusion-related deaths, although rare, are caused due to transfusion-related acute lung injury (TRALI) with a frequency of 15 to 20%, or avio-hemolytic reactions with a frequency of 10 to 15%, and bacterial contamination of platelets with a frequency of 10 to 15%. Blood transfusion reactions may be classified into 6 types. They can be acronymed as ANABTT. Acute hemolytic reactions, these are the most common reactions. Non-hemolytic febrile reactions, these are also fairly common. Allergic reactions, bacterial contamination reactions, transfusion-associated circulatory overload (TACO), transfusion-related acute lung injury, acute hemolytic reactions. Blood transfusion reactions usually take the form of an acute hemolytic reaction. These are severe immune-mediated transfusion reactions due to the administration of avio-incompatible blood. It can be fatal in up to 6% of cases. They are caused by IgM type anti-A, anti-B, or anti-AB antibodies. Transfusion reactions caused by IgG, Rh, KALE, Duffy, or other non-avio antibodies are usually milder and self-limiting. Technical or clerical laboratory errors are the main cause of these reactions. Acute hemolytic reactions are humoral immune reactions and cause activation of phagocytes and production of pro-inflammatory cytokines. Acute hemolytic reactions share many features of systemic inflammatory response syndrome (SIRS). Immediate hemolytic reactions are characterized by intravascular destruction of red blood cells leading to hemoglobinemia and hemoglobinuria. Acute renal insufficiency may result from the free hemoglobin in the plasma, resulting in acute tubular necrosis (ATN) and precipitation of hemoglobin within the renal tubules. Delayed hemolytic transfusion reactions occur 2 to 10 days after transfusion and are characterized by extravascular hemolysis, mild anemia, and unconjugated hyperbilirubinemia or jaundice. They occur when there is a low antibody titer at the time of transfusion. Non-immune mediated hemolytic transfusion reactions occur due to improper storage of blood products when red blood cells are damaged before transfusion, resulting in mild hemoglobinemia and hemoglobinuria without significant clinical symptoms. Non-hemolytic febrile transfusion reactions or NHFT reactions. Febrile transfusion reactions are non-hemolytic and are defined as an increase in temperature of about 1 to 2 degrees centigrade associated with a blood transfusion. These are fairly common, comprising approximately 1% of all transfusions. These are usually caused by a graft versus host response or GVH response due to cytokines present in the leukocytes of transfused red cells or platelet components causing fever, chills, or rigors. The blood transfusion should be stopped immediately. The incidence of febrile transfusion reactions can be greatly reduced by the use of leukocyte-depleted blood products or leukodepleted blood. Pre-treatment with paracetamol or acetaminophen reduces the severity of the reaction. Allergic transfusion reactions. Allergic blood transfusion reactions are relatively frequent, occurring in about 1% of all transfusions. These reactions are usually mild and typically present as rash, urticaria, pruritus, and facial flushing. In rare instances, anaphylactic shock and attacks of angioedema may develop. Transfusion-related allergic reactions are IgE mediated. Allergic reactions are caused by the transfusion of antibodies from hypersensitive donors or the transfusion of antigens to which the recipient is hypersensitive. Bacterial contamination of donated blood. Bacterial contamination of donated blood products may result from three factors: non-sterile blood collection site, non-sterile blood carrying container, and bacteremia in the donor circulation at the time of blood collection. In these settings, the bacterial endotoxins gain access to the recipient circulation and may set up transfusion reaction. Transfusion-associated circulatory overload (TARCO). Transfusion-associated circulatory overload occurs when the volume of the transfused blood component and that of any other infusion cause excess fluid in the circulation, known as circulatory or volume overload. This may lead to acute pulmonary edema and that may be fatal. Transfusion-related acute lung injury (TRALI). Acute lung injury due to blood transfusion may occur due to the presence of antibodies like anti-HLA or anti-HNA in the donated blood. These react with the recipient's blood antigens and induce pulmonary capillary leakage and pulmonary edema. This type of transfusion reaction occurs in the setting of infection, recent surgery, or ongoing inflammation. A history of previous blood transfusion or pregnancy is not relevant for the diagnosis of a febrile non-hemolytic reaction. Transfusion reactions may occur during the first transfusion or subsequent transfusions. A transfusion candidate known to have red cell antibodies from previous transfusion or pregnancy should be informed and proper consent taken. Ask patients about any history of previous transfusion or any complications or previous blood bank antibody problems. How to recognize a transfusion reaction? Acute hemolytic reactions may manifest either early or late. Early signs are fever, facial flushing, jaundice, pallor, low blood pressure, wheezing, anxiety, and or red colored urine due to hemoglobinuria from acute hemolysis. Late signs are generalized bleeding tendency due to disseminated intravascular coagulation and hypotension. Non-hemolytic febrile reactions typically cause only fever. Allergic reactions typically present with rash and or urticaria without fever or hypotension. Anaphylactic reactions manifest as dyspnea, wheezing, anxiety, or hypotension without fever or breathlessness, or in any combination. Transfusion related acute lung injury TRALI manifests as rapid onset of dyspnea, hypoxemia, and rales. Circulatory or volume overload manifests as shortness of breath, rales, orthopnea, tachycardia, or dilated jugular veins. Bacterial contamination presents as high fever, hypotension, tachycardia, and weak pulse without any known focus of infection. How to treat a transfusion reaction? When a transfusion reaction is suspected, the transfusion should be immediately stopped. An intravenous line of 0.9% saline should be kept open. Maintain urine output at more than 1 ml per kg per hour. The product bag should be examined and patient's identity should be confirmed. Vitals such as pulse, blood pressure, temperature, and SpO2 should be monitored and recorded every 15 minutes. A post-transfusion blood sample of the recipient should be sent to the lab. The blood bank should do additional testing and clerical checks to rule out an incompatible transfusion. Treatment of transfusion reactions is most often supportive, such as IV fluids, anti-allergic medication, intubation, oxygen therapy, vasopressors for hypotension, such as IV fluids, anti-allergic medication, intubation, oxygen therapy, vasopressors for hypotension, and epinephrine 0.3 mg IM stat or an IV epinephrine drip if there is severe bronchospasm or airway edema. Manage hyperkalemia if there is severe hemolysis. Transfuse fresh frozen plasma if there is DIC. How to prevent a transfusion reaction? To prevent transfusion reaction, all potential recipients and donors should have ABO and research typing done to ensure compatibility. Immediately before transfusion, a cross-matching or mixing of the recipient's serum with the donor's is done to confirm ABO, RH, and any other blood group antigen antibody compatibility. Full cross-matching usually takes up to 45 minutes. Cross-matching is done either by the conventional WHO collection testing and transfusion or CCT kit or by column agglutination technology. In emergency situations, the universal donor group O may be given, O negative to females and O positive to males. The prescription and the level of the donor blood should be doubly checked by at least 2 persons. The donor blood serial number should also be checked against the issue slip for the recipient. If these steps are strictly followed, the number of severe and fatal ABO incompatibility reactions can be minimized. Confusion with other similar disorders. An inexperienced physician or nurse may be confused with disorders that may present similarly, such as urticaria, angioedema, cardiogenic pulmonary edema, food allergies, hemolytic anemia, immediate hypersensitivity reactions, etc. To avoid this confusion and misdiagnosis, workup or testing should include visual inspection of the recipient's plasma and urine, regrouping and retyping of donor and recipient red blood cells, direct Coombs test, and centrifugation of the recipient's urine to distinguish between hematuria and hemoglobinuria. The Coombs test is usually positive and the blood bank must identify the antigen to prevent subsequent reactions.